Good morning. Thank you very much for coming joining us for Grand Rounds. Dr. Teach is going to introduce our speaker today.
Well, good morning, everyone, and thank you for coming to this very special Grand Rounds on behalf of Dr. Tuckman and Dr. Batshaw and the Children's Research Institute, and particularly on behalf of the Clinical and Translational Science Institute at Children's National. We're incredibly pleased today to welcome Dr. Lisa Guay-Woodford for her presentation on polycystic kidney disease, clinical practice, research advances, and new therapeutic strategies. Dr. Guay-Woodford is a graduate of Harvard Medical School and did her pediatrics internship, residency, and a fellowship in pediatric nephrology at Children's Hospital Boston. She stayed there briefly as an attending physician and on faculty at Harvard Medical School before moving to the University of Alabama, which she has called home since 1994. Alrighty. Where she also serves as attending physician at University Hospital and the Children's Hospital of Alabama in Birmingham. She currently serves as the Anderson Family Endowed Chair in Medical Education, Research, and Patient Care, as well as Professor and Vice Chair of the Department of Genetics at the University of Alabama at Birmingham. As an investigator in pediatric nephrology, her research focuses on identifying clinical and genetic factors involved in the pathogenesis of inherited renal disorders, most notably autosomal recessive polycystic kidney disease. In addition to her investigative work and clinical activities in nephrology, she currently serves as the founding director of the University of Alabama's Center for Clinical and Translational Science, which is funded by a Clinical and Translational Science Award from the National Institutes of Health. Dr. Guay-Woodford.
Great, thanks. Thank you very much, Stephen, for that very kind introduction. It's really a pleasure to be here today. I had a wonderful day yesterday meeting with various folks that are associated primarily with the CTSI. And I think it's a very appropriate thing for someone who runs a CTSI to be an active investigator themselves and to have a foot in the domain of investigative scholarship, be that at the bench or in the clinic, and also have to have a foot in the clinical domain, in a sense because it gives you skin in the game and you understand the issues. My passion is polycystic kidney disease. It's a passion that began at Children's in Boston, as Craig Peters well knows. We've had many, many discussions about PKD during our training. And so what I wanted to do today in the next 45 or 50 minutes or so is to basically give you an update on polycystic kidney disease. To start with the clinical issues that we have come to appreciate in more precise detail, in a sense to move from the Journal of Anecdotal Medicine to a more evidence-based understanding of the clinical disease. To talk about recent research advances, particularly advances in understanding the molecular pathogenesis of the disease. And then to use that as the stepping off point to begin to talk about some exciting new therapeutic strategies that target these pathways, so that instead of just being able to provide supportive care as the disease progresses, that we can actually target the disease at earlier points of the disease course. So since this is Grand Rounds, and I do this primarily for the house staff and the fellows, I thought it would be useful to start with a case presentation. Now, I can tell you when I was in Boston, we always started Grand Rounds with a case presentation, and I very often had the sense that it was a made-up case. This is a real case. I took care of this family. A 22-year-old previously healthy prima gravida presented for a routine obstetrical ultrasound at 20 weeks gestation. Her male, appropriate for gestational fetus, was noted to have large echogenic kidneys and no evidence of major malformations. And everybody said, this is ARPKD. No family history, ARPKD. But when the mother had a follow-up renal ultrasound that it took a little bit of discussion to have her go ahead and pursue this, she had normal-sized kidneys with a normal echo pattern, but she had 2 cysts. Now remember, she's 22 years old. And so I present this case to say not everything that is big and bright in a fetus in terms of their kidneys is ARPKD. And I hope by the end of this conversation, you will be able to recognize that this is a child with a perinatal onset of the dominant form of polycystic kidney disease. So we call it the dominant form of polycystic kidney disease because that's its mode of transmission. It is really a misnomer to call it adult polycystic kidney disease because that's what this cherub has. So in the next bit of time, what I'd like to do is give you an overview of the clinical features that are observed in ADPKD and ARPKD, to talk about new diagnostic strategies, both in terms of imaging and gene-based testing, to talk about new methodologies to assess disease progression. And again, from the perspective of being a physician scientist who's interested in new clinical strategies, one has to understand the natural history of the disease, because what you look for in clinical trials, very simply put, is a deviation in that line in terms of what would be the natural history of the disease, to say that you have efficacy. And so with that in hand, then I'd like to segue into the pathogenic pathways that seem to be in play in the pathogenesis of the renal cystic diseases, and finally to talk about new therapeutic strategies that are coming down the road. I'd make a brief parenthetical aside. This setup is intended to suggest that both the dominant and certainly the recessive form of PKD, our therapeutic window for initiating therapy in the next 10 years is going to be in a pediatric purview. And so we'll talk about why that's the case as we go through this talk. So let me begin with an overview of the clinical features. First, the dominant form of the disease. It has a prevalence of about 1 in 800 to 1 in 1,000. It is a pan-ethnic, pan-racial disease. These prevalence figures come largely from Caucasian populations because they have been the most extensively studied. The molecular genetics largely involves mutation in one of two genes, PKD1 accounting for about 85% of the cases of dominant PKD, PKD2 about 15% of the cases. Interestingly, and particularly for a pediatric audience, this is a renal disease that has a bimodal presentation, and we'll talk about this in just a minute. Only 1 to 2% of the nephrons are affected. So here's a very nice schema from a review that's now about 7 years old from the New England Journal that Pat Wilson wrote. Here's the normal nephron with the glomerulus, the proximal tubule, the loop of Henle, the thick ascending limb, the distal convoluted tubule, and the collecting duct. And you can see in dominant polycystic kidney disease that at least theoretically, soap bubble-like cysts can form anywhere along the nephron length, but by and large, they are confined to the distal nephron, and they lead to massively enlarged kidneys. A pathologic specimen here, I don't think you can see this ruler, but the ruler says 15 centimeters. This is from an adult, had end-stage renal disease that had 25-centimeter kidneys. This weighs about 40 pounds that they're carrying around with this cystic mess. In terms of other associations, we now recognize that certainly in adults, from a symptomatic point of view, this is a multi-system disease. Biliary cysts can be a huge problem, particularly for women. Pancreatic cysts, more of an imaging entity than a clinically significant disease. Vascular aneurysms in the brain, in particular, in a subset of families for reasons we don't precisely understand. Abdominal wall hernias, very common, a clinical pearl. If you have a child who has a family history of ADPKD, and particularly a boy, and you're doing a physical exam, and he has an inguinal hernia, they have about a 3 to 5-fold higher incidence of inguinal hernias than the common average population. And so that could be a tip-off that he's actually carrying the gene. And male infertility, we're beginning to recognize, is a feature of this disease. So in terms of disease expression, this is a summary of the major subsets of patients with ADPKD. There is a form, it's a very virulent form of early onset PKD that is largely confined in childhood to the kidneys. It occurs prenatally or at the first year of age. That was what this child had in the case presentation. Unilateral disease is very rare. We don't really know about microalbuminuria or proteinuria. Hypertension, extremely common. Progression to end-stage renal disease, 25% of these children progress to end-stage renal disease by the time they reach maturity. Biliary renal cysts are rare, but we haven't done a comprehensive analysis all the way through adolescence. The incidence of mitral valve prolapse is not really known. Intracranial aneurysms and other systemic manifestations of the disease are uncommon. So primarily a renal disease with rapid progression. Childhood onset disease, there really are two forms. The first form is sort of the anxious parent, Saturday morning, has a friend who's an ultrasonographer, goes to the hospital and surreptitiously looks at the kidneys. That's not what I'm talking about here. What I'm talking about here is symptomatic disease, presenting with a urinary tract infection, hypertension, microalbuminuria. These children, actually up to 20% of them at presentation can have what looks like unilateral disease, but ultimately the other side catches up. And so in the early 80s, there are case reports of people removing a unilateral cystic kidney only to find out it was dominant PKD and the other kidney developed cyst. So they've decreased the renal mass in a bilaterally structural disease for no benefit. But we now recognize that as an issue. Hematuria is common, microalbuminuria and proteinuria are common. Hypertension is common, but certainly not as common as in the very early onset disease or the typical adult population. Renal stone disease, common in the adult population, not so common in children. Progression to end-stage renal disease in these children is very rare during childhood. Biliary cysts is an imaging finding in about 55% of these children, but typically is not a clinically significant feature. They have a higher rate of mitral valve prolapse, very rare but reported cases of intracranial aneurysms, particularly in children who come from families where intracranial aneurysms are associated with ADPKD. And again, 10% of these patients can have inguinal hernias. And I won't go through the features of the adult onset disease, for which many of you, with which many of you are probably familiar. Now, you have this sort of wide spectrum of disease, and the first question is, well, maybe there are just many different genes involved, and you pick off one gene and you get one phenotype, and you pick off another gene and you get another phenotype. And that just doesn't seem to be the case. Because although there are two genes involved, and although there are differences in patients that have one disease defects in one disease gene versus the other, it is really a matter of temporal differences, not the clinical manifestations. So diagnosis in PKD1 is much earlier than PKD2. Overall survival, and this is a combination of progression to end-stage renal disease and death, now this is from a 1999 study, is 53 years in PKD1 and 69 years in PKD2. What's important there is only about 50% of people with PKD1 actually progress to end-stage renal disease. An important consideration for those of us who are thinking about targeted therapies, and as we'll talk about, targeted therapies that have significant side effects. Committing a child to a lifetime of therapy, you probably want to be pretty sure they're on the path to develop end-stage renal disease. If you have PKD1, you are 4 times as likely to develop hypertension, twice as likely to develop symptomatic urinary tract infections, twice as likely to develop macroscopic hematuria, and renal calculi in adults occurs at about equal frequency in PKD1 and PKD2 related disease. Now, if we think about prognostic markers of accelerated disease progression, there are several, and this is obviously important, again, when we're thinking about therapeutic intervention. In terms of PKD1 versus PKD2 disease, this is earlier onset and has a higher frequency of progression to end-stage renal disease. If you are a trans heterozygote, in other words, you have a germline mutation in one gene and a germline mutation in another gene, and this happens in a series of families, particularly in North America, in Quebec, then you have much more serious disease. If you have a contiguous gene syndrome involving PKD1 and PKD2 that sit tail to tail, sort of like Lady and the Tramp with the dogs on the fence, they sit tail to tail, you pick out a chunk of the 3' portions of both genes. They have really terrible disease. I personally take care of several of these children. The worst case is a 4-year-old girl who has kidneys that measure 25 centimeters in length, who had such bad hypertension that when she presented that she had a dilated cardiomyopathy, and all of my cardiology colleagues said, no, this can't possibly be due to her hypertension. We controlled her hypertension, and her heart is smoking and joking. So they always teach us something. Clinical features, very early onset in disease in infancy, again, rapid progression to end-stage renal disease. Male gender in PKD2, about 4 years difference in terms of the onset of end-stage renal disease. And the onset of hypertension before 35 years of age, particularly hypertension that is untreated, uncontrolled, is a feature associated with more rapid progression of the disease. In terms of urinary urinary markers, microalbuminuria and proteinuria, and gross hematuria before age 30 and recurrent episodes. So for me, as a clinician, if I see hypertension in these kids, or I see microalbuminuria or proteinuria in these kids, I put them on ACE inhibitors. Sometimes just for microalbuminuria, even without hypertension. Sometimes without hypertension or microalbuminuria when they are really significantly hyperfiltering, because then again, that is another sort of insult to the kidney. And because of this gross hematuria association, and this makes me extraordinarily popular in the Deep South, is I ask these children not to play contact sports, which of course includes football. And the final thing, and I'll talk a little bit about this, this comes from a recent study, a consortium study called the CRISP study, that we're beginning to realize that this disease is a structural disease that has significant structural progression long before you lose renal function. So this is a marker of accelerated disease progression that we are trying very hard to convince the FDA that it is a marker worthy of use as an endpoint, a primary endpoint in clinical trials. Now, if we switch gears and we talk about the recessive form of the disease, here there seems to be primarily one gene involved. The cystic disease is really phenotypically quite different. It involves a fusiform dilatation of both the cortical and the medullary collecting duct in the classic neonatal form of the disease. And it gives rise to this classic histopathologic picture where this is a section of the kidney, and all of these dilated structures are collecting ducts that are lined up perpendicular to the renal capsule. And this typically leads to very, very large kidneys in that perinatal presentation. In terms of other associations, until very recently, we thought this was a kidney liver malformation complex. In the liver, it's a biliary dysgenesis and fibrosis problem. So as the liver develops, there are ramifications of the portal vein through the parenchyma, or through the mesenchyme, actually. And there is epithelial differentiation around those ramifications that ultimately leads to this fine lattice work of bile ducts. So it's a highly choreographed three-dimensional architectural process. In ARPKD and in a number of renal cystic diseases, for reasons we don't precisely understand, the ramifications, the branching, if you will, of the portal vascular structure is relatively pruned, and the associated development of the bile ducts is very delayed and in fact never reaches terminal differentiation. So you have these very chaotic bile ducts, and that gives rise to a pattern that we as pediatricians recognize as congenital hepatic fibrosis. Now, when I went to Birmingham, it was very clear to me, both from my time in Boston and my early days in Birmingham, that when we talked about ARPKD, we largely quoted one journal, and that was the Journal of Anecdotal Medicine. So there were 5 cases of this, 6 cases of that, and you really can't do very much when you're really trying to counsel families about what is the spectrum of disease. So we set up to develop a North American database, and I'll give this to you sort of as a summary slide. We then wanted to validate what we found with a sort of a replication study, if you will, and a couple of years later, a Northern European, primarily Northern European study led by the group in Aachen, Germany, also published their results. The median age of this particular cohort is older than this cohort, but you can see that many of the features are very similar. The percentages are a little bit different. A couple of things pop out. In the first week or so of life, for reasons we don't precisely understand, but we have some clues, many of these children have hyponatremia. And that's not true of other renal cystic diseases that are inherited as a recessive disorder and are associated with congenital hepatic fibrosis. Hypertension, very common in this disease. We'll talk about the progression to chronic renal insufficiency and end-stage renal disease in a minute. But we recognize that growth retardation was an independent feature of this disease. So when we control for renal morbidities, hypertension, and chronic renal insufficiency, when we control for pulmonary hypertension, this still stood out. And, you know, I think more studies obviously need to be done because these are cohorts of, you know, a couple of hundred patients. But what was also interesting is in both cohorts, the 1-year survival rate was pretty significant. And again, that counteracts one of the things that we talk about in the Journal of Anecdotal Medicine, which is that this is a uniformly lethal disease in the newborn period. And still to this day, in 2011, I will get phone calls from people in the middle of Kansas saying, I have a prenatal ultrasound at 26 weeks. This baby has big, bright kidneys. They tell me it's ARPKD, and the child will die immediately after birth. And they're discouraging me from going to either to Kansas City or to one of the big centers because there's really nothing that we can do. And I think that we really need an evidence base to be able to advise these patients. So that's why we started this study. There was another lovely study, very small numbers from the Mayo Clinic, that talked about the fact that, again, we can't call this disease infantile polycystic kidney disease because while most patients present in the first year of life, there are patients who present in childhood and there are patients who present in adulthood with ARPKD. Now, all of them can have kidney disease. To have just isolated congenital hepatic fibrosis is largely the domain of children who present older than a year of age. Hypertension occurs in all of them. Urinary tract infection, progression to renal insufficiency, proteinuria, very common in all of them. And then hepatomegaly and the features of portal hypertension, again, are evident in each of these populations. So again, just like ADPKD stretches down into fetal life, ARPKD in its presentation can extend into adulthood. Now, in terms of patient survival, I think this was probably the most important study. In our group, if you survive the first 24 to 48 hours with ARPKD, then the Kaplan-Meier curve says there are very few mortal events thereafter. The ADIVA study, the red line, shows death in children who presented in the first year of life. You can see that there are mortal events very, very early in life, but the next mortal event is well into adulthood. So again, important when we think about transitioning these patients to our adult colleagues, because many of them are going to survive to adulthood. And when they survive to adulthood, many of them are going to come with a panoply of renal issues. Some of them are going to be at end-stage renal disease and been transplanted. Some of them are going to have severe chronic renal insufficiency and need that kind of management. Some of them are going to be, as we say in the Deep South, fixing to get chronic renal insufficiency and require transplantation. I know, my daughter laughs all the time when I say it too, but I try. So from the study from Bergman et al., very complicated slide, I'm going to use a series of arrows to point out the seminal features. At 5 years of age, the proportion of patients who have functioning kidneys is 86%. At 10 years of age, it's 71%. At 15 years of age, it's about 66%. And at 20 years of age, it's 42%. So think about that. Those children transitioning to adulthood and to adult care, many of them have various degrees of renal function extending from CKD1 all the way to CKD4, and they require, therefore, a very careful transition plan. And this is corroborated by the work of ADIVA et al. Again, 75% have functioning kidneys at about 10 years of age, and about 50% at 15 years of age. So let's switch gears with this overview of the polycystic kidney disease and talk about how do we make the diagnosis. Well, in terms of imaging, ultrasound is a very useful screening tool for ADPKD. It is not a useful tool for following disease progression. And we can't confuse the two, because I have lots of patients who come to see me from far-flung regions of the United States and even Canada and sometimes Europe that are getting ultrasounds on a yearly basis. Ultrasound is not precise enough to follow the course of the disease, but it's terrific for making the diagnosis. So in fetal life, the tip-off that this may be ADPKD is enlarged hyperechoic kidneys after 17 weeks gestation, usually normal amniotic fluid levels, in contrast to the recessive form of the disease where amniotic fluid levels are reduced, and very occasionally discrete renal cysts. So these are largely big echogenic kidneys. Remember the case that I presented. In children 0 to 15 years of age, enlarged kidneys, more frequent discrete cysts, but again, normal echogenicity. So it's as if these cysts populate the kidney and the rest of the parenchyma is normal, and that's in fact the case. If you come from a family that is known to have ADPKD, one cyst is adequate to make the diagnosis in a child of this age. If you're just screening a population for children in this age, there's about 77% sensitivity and 96% specificity in this age group. So not perfect in terms of using it as a diagnostic tool, unless you're coming from a family where you're known to be, the family is known to be transmitting the disease gene. In young adults, 15 to 30 years of age, ultrasound is less sensitive than genetic testing for PKD1 and PKD2, but it's still pretty good for PKD1. It's PKD2 that's the problem. And the reason is because PKD2 is a more slowly progressive disease. So here is a list of ultrasound criteria that nephrologists like Kowal and I use all the time in thinking about ADPKD. So 15 to 29 years, 2 cysts, either 2 cysts, 1 in each kidney, or 2 cysts in 1 kidney. Remember that mother had 2 cysts in 1 kidney. In 30 to 59 years, 2 cysts in each kidney, greater than 60 years, 4 cysts in each kidney. And the reason for that is because as we age, we develop isolated cysts. Now, Pei recently modified this to say we have to take into consideration patients with PKD2. And the major thing that he did is he extended these 2 groups, 15 to 39 years, so 10 years more, 3 cysts, either unilateral or bilateral, and 40 to 59 years, 2 cysts in each kidney. And this really was published in 2009, and over the past 2 years or so has really stood the test of time when compared to genetic testing. Segue to genetic testing. These are 2 genes. They are not in the genome hugely large genes, but PKD1 is a gene with so it's a compact gene with 46 exons. The problem is, if you go down here further on chromosome 16, headed towards the centromere, there are multiple pseudogenes that share 95%, not similarity, but identity with this gene. And so there have been a whole variety of strategies to come up with doing precise genetic testing, looking at just this gene and not its pseudogenes. What the good news is, when you find sequence changes, they're likely to be pathogenic. They're typically frame shift mutations, insertions, deletions, stop codons, and so you're pretty confident that this is a sequence change that's going to disrupt the function of the protein that is supposed to be made by this gene. And only 22% have missense mutations. PKD2 extends over a longer stretch in the genome, but it only has 15 exons. We have 100% sensitivity in finding mutations in this gene if they're there. The terrific news is if mutations are there, they're very likely to be pathogenic 80% of the time. So putting this all together, I mean, a beautiful study that was done by Rossetti et al. Mutations were identified in the CRISP cohort that I'll tell you about in a minute in about 90% of patients. About 85% of those patients had PKD1, and about 27% of those patients had PKD2. So genetic testing is good, but it's not perfect. You can spend $3,500 to do this test, and 10% of the time, particularly if you have mutations in PKD1, you won't pick up a sequence change. In terms of ARPKD, it's a mess. This is a huge gene. It extends over at least 460 megabases in the genome. It has multiple contiguous exons. The largest open reading frame cDNA contains 67 of these exons, but there are a number of other predicted exons that we have no idea if they figure into transcripts and if they are part of a translated protein. And then the bad news is that when we have done, and numbers of us have done, genetic studies in patients where we really know they have ARPKD, 42% of the time we find missense mutations, often missense mutations in each allele. And that's really hard because missense mutations, in terms of determining their pathogenicity, we use statistical algorithms. And remember, this is a very early onset disease. People make decisions about pregnancy. They make decisions about in vitro fertilization. And so this is really a very big clinical challenge. Plus the fact, as I'll show you in a minute, there are lots of phenocopies of this disease in the newborn period. And that adds another level of complexity. If we look at our diagnostic testing, so remember, 85% of the time we can pick up the mutations when we know this patient has histopathologic features and transmission and linkage studies that suggest it's ARPKD. We do this as a 2-tier test, first concentrating on the 23 exons that contain about 80% of the mutation because it's cheaper. And if we don't find 2 mutations, then we go on and look at all 67 exons. Remember, the other 19 exons we don't look at because we don't know what to make of those data. If you look at the data from May of 2005 to 2010 in doing this at UAB, while in our laboratory, 85% of the time we could detect mutations, only 48% of the time in these patients that came for diagnostic testing to our clinical diagnostics laboratory could we detect mutations. And the reason for that is this. This slide is intended as a wow slide, not to be read. But it's simply to say that all of these disorders have some form of renal cystic disease that in certain situations can phenocopy the renal disease that you see in ARPKD, and they all have congenital hepatic fibrosis. So it's not the renal disease or the presence or absence of congenital hepatic fibrosis that distinguishes this on a clinical basis. It's really the systemic features that are key. But some of these are subtle, and some of these systemic features, for example, in Meckel-Gruber, can be very subtle and can be missed because of incomplete penetrance. So this is the conundrum in dealing with recessive PKD, that there are lots of disorders that can look the same. And you say, well, just do genetic testing. At this point, there are probably 50 different genes that are involved. And even at the Sheikh Zayed Institute, we couldn't afford to do that on very many patients. So let's again switch gears and think about new methodologies to assess disease progression. You know, what do we know about disease progression? Well, I mentioned the gold standard in terms of kidney disease is really kidney function when I was speaking earlier about progression. And so we either talk about the rate of change, and those sorts of features are listed here, or discrete variables such as the frequency of end-stage renal disease. But if you have a disease like this, where this is GFR and this is the structural disease, you can see that the kidney has to be incredibly involved with massive cystic change before GFR stops to drop. This is probably not an appropriate entry point for therapeutic intervention. This is probably the appropriate entry point, but these children all have normal renal function. So there was a UO1 consortium that was established now about 8 to 10 years ago that was designed to be a prospective longitudinal observational study with annual protocolized visits, MRIs, and GFR studies. It was to ask the question, can we correlate GFR with imaging studies so that we can predict, based on structure, who's going to lose function faster? The eligibility were young patients with normal renal function, and we biased this study towards people with hypertension. Again, hypertension being a marker of more accelerated disease. It's an observational study. So to quantify renal volume, we used MRI and we used ultrasound. In adults, ultrasound is not really reliable in the year-to-year quantitation of the severity of the disease, but a serial slicing approach with MRI and putting together renal volume, either in terms of total kidney volume or cyst volume, is really quite effective. And there are numbers of publications from this consortium. I just want to use this slide because it's probably one of my favorite from all of the publications to make a simple point. The difference between PKD1 and PKD2 is not the rate of cyst growth. It's the rate of cyst development. So the blue line here is PKD2, and the red line is PKD1. These are regression lines. And you can see that if you regress this line, that in fetal life is when the cysts are forming in PKD1. And so that's probably why there's earlier onset disease, because PKD1 affected patients have an earlier jump on developing renal cysts. So new insights from this CRISP consortium: renal progression in ADPKD is marked by increases in total kidney volume, and we have determined that if you have massive kidney volume corrected for age, GFR is inversely proportional to TKV. In other words, your renal function deteriorates more rapidly. MRI-based measurements are reliable and provide a valid marker for renal disease progression that detects significant changes over a relatively short period of time. Very important when you go to the NIH and want to do a clinical study. You can't say we need to be funded for 50 years because it isn't going to happen. PKD1 and PKD2 patients differ with regard to the rate of new cyst formation versus the rate of cyst growth and expansion. And this is, I think, probably the key point for pediatricians. The exponential rate of kidney growth or cyst growth in ADPKD indicates that early cyst formation, i.e. in childhood, plays a critical role in disease and progression, meaning that childhood is going to be our therapeutic window. So that's great, but what therapies are we going to use? So let's think a little bit about just the epithelial component of renal cystic disease. And I need to put in a disclaimer here. The progression of renal cystic disease involves not just the epithelial compartment, but involves the development of fibrosis, and it involves the vascular compartment as well. The lion's share of research to date has been done on epithelial abnormalities, so that's where I'll focus. But I want you to keep in mind that fibrosis and vascular issues play into the pathogenesis and the progression of this disease, and therefore also at least potentially provide druggable targets. So here's a summary of what a normal renal epithelial cell does. It has a primary apical cilium that faces into the luminal space that is supported by a centrosome with a mother centriole. It's terminally differentiated. It's polarized. It has a low rate of proliferation and apoptosis. It has intact cell signaling and cell contacts. In other words, the signaling within the cell is a really beautifully integrated circuit that works extremely well to regulate transport processes, et cetera, et cetera. And these cells hold hands with one another well, and they hold hands with the basement membrane well. In cystic epithelia, there is a relative dedifferentiation. There are some polarization defects. There's increased proliferation and increased apoptosis, but in the renal cystic diseases, particularly PKD, there's more problems with proliferation than apoptosis. That's why these kidneys get to be so large. There are defects in cell signaling pathways and the integrated circuitry within the cell, as I'll talk about in a minute. There are defects in the cell making appropriate contacts with its cell membrane. So how do we sort this out? Well, it has been said that the experimental model of the 21st century is the human being, which is terrific, except we've been working on this disease for a very long time and had very few insights, except to keep increasing the number of genes that were involved in causing renal cystic disease. And then we went to our friendly experimental model of the mouse, and all of these genes are expressed in the mouse, and if we pick off these genes in the mouse, we get diseases that pretty much mimic the human disease, and then the mouse spontaneously has picked off a whole other variety of genes that give disease that phenocopies human disease. So now we have all these genes that cause renal cystic disease with congenital hepatic fibrosis, and we were still no further in having real insights. And then a comparative genomic study was done, and I say this because there has been a push in Congress recently to really focus on human beings for research. That the idea of looking at these simple models is really just not, helpful. And over and over and over again, we realize there's folly in that thinking. You can't translate what you don't know. And these experimental models that are so simple give us incredible insights. So, for example, there is a mutation in this protein, in the green algic chlamydomonas, that if you have a defective gene here that doesn't make a protein, you don't get these flagella. And chlamydomonas can't live without those flagella. If you have a defect in this gene in the nematode C. elegans, they can't mate because there's a structure, a cilial structure, that is critically important in them sensing their environment. And if you have a defect in these ciliated structure on the renal epithelia that I showed you before in the ARPK mouse, so that they're short, stubby little structures, then you get renal cystic disease. And so that was the first insight to say the primary apical cilia is an important player in this integrated circuit that, that causes renal cystic disease pathogenesis. So what is the primary apical cilia? Well, I've already kind of given you a brief overview. Extending from this mother centriole is a primary cilium that's based on a microtubule scaffold or axoneme. Along the course of this primary apical cilia are channels, receptor, effectors like transcription factors, and as I'll talk about in a minute, a whole bunch of cystoproteins that can either move whole out of the cilia to the nucleus and regulate transcription, or cleavage products can do that. And in doing this sort of very highly integrated signaling pathway controls cell proliferation, mitotic spindle organization, cell differentiation, tubular organization, and the maintenance of tubular architecture. So again, just a brief summary slide. These are the major genes that are involved in renal cystic disease. They are all expressed, at least in part, in the primary apical cilia or in the centrosome. And in the interest of time, I won't say much more about what, it's an unbelievably cool biology about scaffolding and movement of proteins, and the tip being a sort of a signal organizing center. We've learned an enormous amount about what was once thought to be a vestigial organelle. If we think about the cilia and abnormalities in cell signaling, we know that ciliary function is altered in particularly ADPKD, but now in a variety of renal cystic diseases. Beautiful work by Jingzhu and company demonstrated that when the cilia is bent, it sets up a calcium transient that moves into the cell. It's amplified by calcium release from the endoplasmic reticulum, and it controls the level of cyclic AMP. Increased cyclic AMP is a cardinal feature of cystic epithelia, and it wreaks havoc in that integrated circuitry, as we'll talk about in a minute. There's altered Wnt signaling. Wnt signaling is a hugely important signaling pathway in renal development, and so we've come to appreciate is sonic hedgehog. And finally, cystoprotein signaling itself is very important in renal tubular, in epithelial differentiation and renal tubular differentiation. So I'm very quickly going to go through these pathways. In terms of Wnt signaling, there are two pathways. There's the canonical pathway, which is involved in proliferation. And what happens in this pathway is the soluble factor Wnt, or a series of Wnts, bind to their receptors, the frizzles, and activate this protein disheveled, which puts a block on this destruction complex. Therefore, beta-catenin can move merrily from the basolateral membrane into the nucleus to cause the transcription of a number of pro-proliferative molecules such as c-Myc. With the bending of the cilia, inversin moves to the centriole, and probably so do some Bardet-Biedl proteins. They then, in turn, cause disheveled to be ubiquitinated and destroyed in the proteasome. And therefore, this destruction complex destroys beta-catenin, and that cell that transcriptional signaling process for beta-catenin is lost. And so this seems to be a pathway that's critically involved in differentiation. So while you're making the elements of the kidney, you want proliferation. When you're trying to differentiate tubular structures, you want differentiation. And so one of the things that we've come to realize is that there's this process called planar cell polarity that is involved in the non-canonical Wnt signaling pathway. And simply put, it lines up the mitotic spindles so that when the cells divide, they divide along the axis of the tubule, making a stereotypic tubule. And when that doesn't happen, the thought is you end up with a cystic structure. But there's a caution here, because nothing is ever as simple as it first seems. And Steve Somlo has demonstrated that you have lots of loss of planar cell polarity and the oriented cell division axis in ARPKD long before you have any cysts. And in ADPKD, that's true as well. So it's more complicated than just disrupting planar cell polarity. But this certainly does seem to be a part of the process of cysts evolving. In terms of sonic hedgehog, in the interest of time, I'm simply going to say that sonic hedgehog is a very important process in morphogenesis, patterning, and tubular homeostasis. And when sonic hedgehog binds to its receptor patched, it stops the progression of this protein, or it allows the progression of this protein smoothen into the cilia. It changes the state of these Gli regulatory proteins such that these Gli regulatory proteins become repressors and allows morphogenesis, patterning, and tubular homeostasis. So this is a developmental disease. And I'm going to skip these slides in the interest of time and get to the cell signaling abnormalities that we've come to understand. So we know there are problems with the cilia and calcium influx. We know, particularly in ADPKD, that there are two or three major processes. There's abnormal proliferation and abnormal secretion. So if we could target those pathways, maybe we'd have effective therapies. All of the targets that I'm going to talk about have been effective in animal models. The human studies are indicated by an asterisk, and you can find them at clinicaltrials.gov. This cartoon comes from a lovely review by Vince Torres in the Annual Review of Medicine. And I'm going to use this to summarize the data to date. So if we think about therapeutic targets that are going to target increased cyclic AMP, we have to understand that the major effectors for cyclic AMP, the agonist is the vasopressin receptor, and the antagonist is the somatostatin receptor. And so having drugs that are V2 receptor antagonists and somatostatin agonists decrease intracellular cyclic AMP. We also know that increased cyclic AMP stimulates SRC, and so SRC kinase inhibitor, bucitinib, is effective in animal models and is now just being started to study in ADPKD patients. And finally, the secretory portion here, the CFTR, cyclic AMP promotes secretion that is mediated by the cystic fibrosis protein, leading to increase in size of cysts. In animal models, I think this is the panel that you want to look at. A is a littermate with 2 mutations in the PKD2 gene. B is a littermate with 2 mutations in the PKD2 gene that was treated with this antagonist. I think it is clearly remarkable that, this disease has been attenuated so dramatically. Now, there are international studies on this V2 receptor antagonist that show great promise. And this is a study that's combined from studies initially done in the United States and Japan. And I'll let you read this, but just sort of give you the take-home point. These patients were matched for total kidney volume, huge kidney volume. The average adult kidney volume is 300 ml. So these people had huge kidneys. And they had some decrease in GFR. And when they completed 36 months of the study, all experienced adverse effects. And that caused some people to withdraw. But if you look at total kidney volume, the increase was slowed in those that were treated with Tolvaptan versus those that were control patients. The problem with Tolvaptan is the receptor is only in the kidney. So this is not applicable for the liver disease that's associated with ARPKD, but it does show promise. And in early 2012, the phase 3 trial results will be published. And so this may be the first targeted therapy, primarily for use in adults, but it will set the stage for studies in children. If we think about the hyperproliferation, mislocalization of the EGF receptor that's functional is a huge problem in many of the animal models and the human renal cystic diseases. We talked about SRC kinase being a mediator as well. TNF alpha is a mediator. MEK, the MEK pathway here is a mediator as well, as is BRAF. And because this is because the centrosome is so tied to cell cycle regulation. Cell cycle regulation is disrupted in this disease, and a cell cycle regulator inhibitor, roscovatine, has proven to be an effective drug as well. So in clinical trials, this actually started in clinical trials, but there were too many side effects. Useful in cancer, but huge side effects. So now the focus has moved to SRC kinase inhibitor. MEK inhibition, again, in clinical trials in ADPKD. And finally, roscovatine as a cell cycle inhibitor. And this is just a study to show that the mislocalized EGF receptor, this is the kidney untreated, this is the kidney treated, this is the liver untreated, this is the liver treated. So it really seems to attenuate the disease, which is nice because it affects both organs. In terms of other therapeutic strategies, you've all heard about some of the mTOR studies and the very apparently disappointing results in the New England Journal in the last 6 months. And the way that this works is that mTOR activity is known to be increased in both renal epithelia from human patients and also from animal models. And the idea here is that polycystin-1 tethers one of these tubular sclerosis proteins to the membrane and allows it to interact with hamartin to put a brake on this GTPase Reb, and that puts a brake on this mTOR pathway. If you disrupt polycystin-1, or in fact a number of other proteins that in animal models or in humans cause renal cystic disease, the brake comes off mTORC1 and it leads to protein synthesis, cell proliferation, cell growth, and cystogenesis. But there are mTORC-independent effects that, in the interest of time, I'll simply say that affect cilia length and therefore likely cilia function that contribute to the cystogenesis. Now, one point I want to make here that I'm going to come back to is that this is one way to put a brake on mTORC, but this is a drug with a lot of side effects. The way to amplify the effect of rapamycin is to use AMPK stimulators. And for those of you who have a few more life experience units, you will recognize that we use AMP agonists all the time in our diabetic patients when we use metformin. And it's a drug with a relatively low side effect profile. So keep that in mind as we talk about these two studies. The first, these were back-to-back studies in the New England Journal. The first is with Everolimus. It was an 18-month open-label study, randomly assigned patients. At randomization, the total kidney volume was equivalent. And at the end of the study, the EGFR did not, or the renal function did not differ significantly between the two groups. And so they concluded that in patients with ADPKD and early chronic kidney disease, 18 months of treatment with sirolimus didn't halt kidney growth. And the PKD world was dashed. I mean, we were just, beside ourselves. But if you really read the study, they used a very low dose of rapamycin. They still had a quarter of their patients who dropped out. Was the study adequately powered to really look for an effect? Was it long enough? Did they choose the right patients? The study design is critically important. Now, a much larger study conducted by the Germans, where patients had worse renal function, showed that within a 2-year study period, as compared with placebo, this rapamycin analog slowed total kidney volume of patients with ADPKD, but the decline in renal impairment continued. Well, that's not good, because that's the key issue, is slowing the decline in renal impairment. But again, fully a quarter of the patients in this study had to withdraw or have their dose changed, because rapamycin is a very toxic drug. So it speaks to the possibility of combination therapies with rapamycin and perhaps metformin, rapamycin and perhaps TNF-alpha inhibitors that may be more efficacious. So this is a first pass look that wasn't as promising as we would like to think. But I think many of us in the field aren't quite ready to get rid of rapamycin. From a pediatric perspective, this is a drug with a high side effect profile. So we better damn well figure it out, because we would be committing patients to a lifetime of therapy with a somewhat dangerous drug. There are other therapeutic agents. There's an herbal medicine, triptolide, that seems to affect the release of calcium from the endoplasmic reticulum, actually stimulating it so that it can decrease cyclic AMP. Apoptosis is an underappreciated process that certainly occurs in this disease, and at least in animal model studies, caspase inhibitors have been shown to be efficacious. So that's wonderful for ADPKD. There's lots on the horizon. What about the recessive form of the disease? The bottom line to this slide is we don't have markers to assess disease progression. And without markers to assess disease progression, we can't do clinical trials, although all the pathways I showed you and all the drugs that I showed you work in animal models of ARPKD. So our major challenge is to come up with markers. I don't think imaging is going to be the answer, because in ARPKD patients, as patients age, their kidneys actually shrink, probably through the consequences of renal scarring and the loss of nephrons. So we're working on other approaches, like metabolomic approaches, looking for signatures that are associated with more severe disease as biomarkers of more severe disease. We're also trying to collect these patients and carefully phenotype them. There are 2 studies. One is our P30-funded center at UAB. Another is at NHGRI. Be interesting to come to Washington, because I collaborate closely with these folks at NHGRI in their clinical center. This is our portal, and for pediatricians, like my nephrology colleagues who are extremely busy, and someone comes up with a rare disease that they want to study, and you have to go to the IRB, you're like, I like you, but I don't like you that much. And so, so what we did is we had the patients initiate this process. They go to the website, they pull down the informed consent and the information. They read it, they contact our clinical nurse. Actually, she gets an email to say that someone has pulled down the information. They discuss it, they sign the consent, they send it back to us. We send the clinicians an email saying, your patient has given us informed consent to ask you to go to our web-based portal and to fill in their information. And this makes my colleagues here, for example, at GW, they are not participants in this research studies as investigators. They are simply complying with their patients' wishes. And that allowed us to collect a large number of patients because our first database took quite a hit when the HIPAA rule came in 2004. So we have a clinical database. We've married it to a mutational base, not just from mutational data studies that come from our institution, but also from the NIH, from the Mayo, and from the Marshfield Clinic as well. And we have a whole suite of educational resources, some for patients and some for healthcare providers. And if you're interested, this is the website. So in summary, PKD is a clinically significant disorder in children and adults. Diagnostic strategies to distinguish the two are improving, but it's very important to understand that genetic testing, simply because we know the gene, genetic testing doesn't help us as much as we would like clinically to make the diagnosis. You have to be really confident of what you're looking for to have this genetic testing actually be revealing. So when it's an unknown case, you can do the genetic testing, but recognize you may come up with nothing, and it's an expensive nothing. While phenotypically distinct polycystic kidney disease share common features and pathway, this is the hook for the future. This is how we will move studies from adults into children, because the pathways are very similar and the results are very similar if we have markers of disease progression. And clinical trials, as I mentioned, are in process with these agents targeting the pathogenic pathways in ADPKD because they're adults and because we have progression markers. So I'd like to conclude by acknowledging some of the people at UAB who have helped with these studies, the ARPKD consortium with whom our group worked to identify the PKHD1 gene, the members of the CRISP consortium around the country, and of course our funding sources from the NIH in forms of R01s and our P30 Core Center and the PKD Foundation. And for those of you who have now caught the PKD bug and would like a brief list of references that might be helpful to you, every time that I give a talk on this theme, I always update this slide because there is increasing interest and increasingly important clinically relevant publications that are coming out in the literature. And so I will leave this slide up and be very happy to answer any questions.
Thank you very much for such wonderful presentation. And we do have about 1 or 2 minutes for questions. We have Mike in the center. If there are any questions at this moment, Dr. Batcher.
Great talk, Lisa. Thank you so much. I think it shows how you can really go from T1 to T3 work in a rare disease in a beautiful fashion. When you're talking about the mTOR and the approaches there, and obviously that's also, as you mentioned, important for tuberous sclerosis. And is it possible that one can use both models to come together to figure out what might be an appropriate approach?
Yeah, it's a terrific question, Mark. The problem, and I didn't have time to get into it, is if you look at the renal epithelia in a kidney that has a renal cystic disease, ADPKD, the other renal cystic disease, it's not all cells that have activation of mTOR. It's a subset of cells. And so I think in renal cystic disease, the mTOR pathway, the dysregulation, particularly of the mTOR fork of the pathway, is a player in the pathogenesis of the disease. But it's not the whole story like it is if you disrupt hamartin or tuberin, the TSC1, TSC2 proteins. So I think that it will play a role. The side effect issue is enormous. It's an issue for the efficacy of these clinical trials, and I think combination therapies are going to be really important. I mentioned metformin. I mentioned TNF-alpha, which is not a trivial drug. TNF-alpha inhibitors, which are not trivial drugs either. But I think that while we can learn some lessons from tuberous sclerosis that apply to PKD and vice versa, the pathogenesis is fundamentally different. And so we, for example, might learn something because there are now clinical trials that are not only looking at rapamycin to control the subependymal nodules that you see in tuberous sclerosis and even the facial angiofibromata, but the renal disease as well. Those studies may give us insights to how we can best use rapamycin in other cystic kidney disease in a safe way, and how we can think about the combination therapy that's probably going to be required. Hello, Michelle.
Lisa, thank you. That was such an elegant translational overview. In preventive cardiology, we think a lot about PPAR pathways because they're just such global regulators of all things vascular. And I was intrigued that that global regulator, which quite well, though I haven't looked at this renal literature, is upstream of many of the things you're talking about, in utero shows promise in an animal model in any event. I mean, that's exciting because you have endogenous ligands. They're wired to all sorts of essential fatty acids. And I'm wondering, well, two things. One, is there hope in human pathways, or is it that would have to start too early before we have good biomarkers to identify risk? Or, and/or, is there any evidence in the nice longitudinal work you've set up through your registry of lifestyle factors, dietary factors, nutritional roles in progression of disease?
So I think, hugely important when I talk about ARPKD and the variability in the disease, both in the whole cohort of ARPKD and within families, I primarily focus on genetic factors because it's an early onset disease. And unlike some of the cardiovascular work, the lovely work that's been done looking at environmental factors that have gene by environment interactions, we just don't have the tools to do that as well. It's all very epidemiological. For example, in ADPKD in adults, we know they shouldn't smoke because it accelerates disease progression. We don't know that in children. So that's one answer to the second part of your question. The first part of your question is fantastic, and that's the PPAR story. So the Japanese it's probably 6 years ago, did a study in an animal model of ARPKD with pioglitazone. And it worked beautifully. But there have been some problems in some of the animal studies that have really sort of dampened that approach. But you're absolutely right. If you're looking for a magic bullet in ARPKD or ADPKD, even with the PPARs that are upstream of a number of these pathways, you're not going to find this. But this is probably a disease that's going to be like cancer. And so to decrease the toxicity profile, we probably want to use a combination of these drugs at lower levels. And if we do that, then we probably want to do this in a hierarchical way where we're targeting things that are upstream with a drug, and then its players downstream, recognizing it's an integrated circuitry. But at least that we're making our way through this circuitry in a hierarchical fashion that is tolerable in terms of side effects. What worries me most is these drugs have huge side effects. 50% of people go on to end-stage renal disease. The analogy to cancer is not precise because cancer, you're either treated or you die. In this disease, you're either treated or you go one of two ways, and we don't know how to predict that so well right now. You have cysts, and lots of people can live with cysts and normal renal function, or you progress to end-stage disease. So I think there are a lot of ethical issues as we think about how to use these agents. I didn't mention the PPARs, but I think that absolutely will become part of the armamentarium for consideration.
Thank you.
Thank you very much, and thank you for staying with us.